Picture this. It's 1890, and you walk into a respectable physician's office in downtown Boston. The waiting room is filled with well-dressed women, all suffering from the same mysterious ailment. Behind closed doors, the doctor is treating patient after patient with what he calls therapeutic massage, using a mechanical device that would make your Victorian ancestors faint and your modern self do a double take. By 1900, this device had become the fifth electrical appliance to be domesticated in American homes, adopted faster than vacuum cleaners and irons. We're talking about vibrators, and yes, they were literally prescribed by doctors as legitimate medical treatment. You think modern medicine has some questionable practices? Buckle up, because we're about to dive into one of history's most bizarre medical phenomena, a story where respected physicians, constrained by social taboos and genuine ignorance, created an entire industry around treating female hysteria with mechanical stimulation. This isn't some fringe medical practice we're talking about. This was mainstream, accepted, and profitable medicine that lasted for decades. Before we dive into this absolutely wild chapter of medical history, if you're ready to have your mind blown by just how strange and fascinating Victorian medicine could be, smash that like button and subscribe. We explore history's most bizarre and eye-opening stories every week, and trust me, you won't want to miss what's coming next. I'm always curious about our amazing global community, so drop a comment with where you're listening from and what time it is there right now. Now settle in and get comfortable, because we're about to take a deep dive into a story that will make you question everything you thought you knew about medical professionalism, Victorian morality, and the lengths society will go to maintain its delusions. To understand how we got to a place where doctors were prescribing vibrators, we need to step into the mind of Victorian medicine and confront one of the most successful medical hoaxes in human history. Hysteria wasn't just a diagnosis. It was an entire worldview about women, their bodies, and their place in society, wrapped up in the authority of medical science. To understand how we got to a place where doctors were prescribing vibrators, we need to step into the mind of Victorian medicine and confront one of the most successful medical hoaxes in human history. Hysteria wasn't just a diagnosis. It was an entire worldview about women, their bodies, and their place in society, wrapped up in the authority of medical science. The roots of this delusion stretch back over 2,000 years to ancient Greece, where physicians like Hippocrates proposed that many female ailments stemmed from a wandering womb. Yes, you heard that right. Greek doctors literally believed that the uterus could move around inside a woman's body like some kind of internal nomad, causing various symptoms depending on where it decided to settle. If it wandered up toward the heart, a woman might experience shortness of breath. If it drifted toward the brain, she might suffer headaches or emotional disturbances. The prescribed cure? Marriage and pregnancy, which would supposedly anchor the restless organ in its proper place. But the Victorians, never content to leave a good delusion simple, took this ancient nonsense and transformed it into something far more elaborate and profitable. By the mid-1800s, hysteria had become the Swiss Army knife of medical diagnoses, a catch-all explanation for virtually any behavior or symptom that didn't fit Victorian ideals of feminine propriety. The list of hysteria symptoms reads like a catalog of human experience itself. Anxiety, hysteria. Depression, hysteria. Irritability or mood swings, definitely hysteria. But here's where it gets really telling. Sexual desire in women was also considered a symptom of hysteria. So was assertiveness, intellectual ambition, and what we might now recognize as perfectly normal expressions of frustration with extremely limited life options. Dr. Silas Weir Mitchell, one of the era's most prominent neurologists, described hysteria as the nosological limbo of all unnamed female maladies. What he meant, though he probably didn't realize it, was that hysteria had become the medical profession's way of pathologizing the female experience itself. Any woman who didn't conform to the Victorian ideal of passive, cheerful domesticity could find herself diagnosed with this mysterious condition. The scope of this diagnosis was staggering. Medical texts from the 1880s list over 75 different symptoms that could indicate hysteria, ranging from the physical, headaches, fatigue, muscle spasms, to the psychological, excessive emotionality, inappropriate sexual feelings, or unnatural intellectual interests. One physician, Dr. Thomas Stretch Dowse, published a comprehensive guide in 1886 that included, among hysteria, symptoms, a tendency to cause trouble for others, eating like a plowman, and wanting to remain single. Think about that last one for a moment. In Victorian medicine, a woman's desire to remain unmarried was literally considered a symptom of mental illness requiring medical intervention. The economic incentives behind hysteria diagnosis were enormous and largely overlooked at the time. Unlike many medical conditions that doctors might cure permanently, hysteria required ongoing treatment. Women didn't get hysteria once and recover. They were chronic sufferers who needed regular medical attention. For physicians building their practices, hysteria patients represented reliable, repeat customers who would return week after week, sometimes for years. Dr. Rachel Maines, the medical historian who first brought this phenomenon to widespread academic attention, discovered that by the 1890s, hysteria had become one of the most commonly diagnosed conditions in America and Europe. Some physicians built their entire careers around treating hysterical women, seeing dozens of patients per week for what they called therapeutic massage. But here's the part that would be funny if it weren't so tragic. Nobody, not the doctors, not the patients, not the husbands who paid the bills, was supposed to acknowledge what was actually happening during these treatments. The medical profession had created an elaborate fiction that allowed them to provide sexual release to women while maintaining that they were treating a legitimate medical condition through purely therapeutic means. Consider the case of Charlotte Perkins Gilman, who would later become a famous feminist writer. In 1887, she was diagnosed with hysteria and subjected to the rest cure, a treatment that involved complete isolation, enforced bed rest, and prohibition from writing or any intellectual activity. Her physician, the same Dr. Silas Weir Mitchell I mentioned earlier, prescribed what he called domestic therapy, essentially telling her to give up any ambitions beyond housework and child-rearing. When this treatment failed to cure her depression and anxiety, she was recommended for mechanical therapy, which included regular sessions with what medical journals euphemistically called manipulative devices. Gilman later wrote about her experience, describing how the medical treatment had pushed her close to the borderline of utter mental ruin. She recovered only when she ignored her doctor's advice, left her marriage, and pursued her career as a writer. But thousands of other women weren't as fortunate or as able to escape the medical system that had labeled their normal human desires and ambitions as symptoms of disease. The most perverse aspect of hysteria diagnosis was how it created a self-reinforcing cycle. Victorian society severely restricted women's opportunities for sexual expression, intellectual fulfillment, and personal autonomy. When women showed signs of frustration, depression, or unfulfilled desire, perfectly reasonable responses to these restrictions, the medical establishment diagnosed them with hysteria and prescribed treatments that provided temporary relief without addressing the underlying social causes of their distress. Dr. George Beard, another prominent neurologist of the era, wrote extensively about what he saw as an epidemic of hysteria among middle and upper-class women. He attributed it to the stresses of modern civilization, completely missing the obvious explanation that women who had been educated enough to recognize their intellectual capabilities might naturally feel frustrated when society offered them no outlet for those abilities beyond marriage and motherhood. The medical literature from this period is filled with case studies that read like textbook examples of sexual frustration being medicalized. One physician wrote about treating a 35-year-old unmarried woman who complained of restlessness, irritability, and inappropriate thoughts. Another described a young wife who suffered from excessive nervous energy and marital dissatisfaction. These weren't mysterious medical conditions. They were the predictable results of a society that simultaneously sexualized women and denied them any legitimate expression of their sexuality. But perhaps the most telling aspect of hysteria diagnosis was who received it and who didn't. Poor women, working-class women, and women of color were rarely diagnosed with hysteria. This wasn't because they didn't experience the same symptoms, but because hysteria had become a fashionable ailment of the leisure class. To be diagnosed with hysteria, you needed the time and money for regular medical treatments, and you needed to fit the Victorian image of delicate femininity that made the diagnosis socially acceptable. The medical establishment had created a perfect system. They had pathologized normal female experiences, created a treatment that provided relief without actually curing anything, and established a client base that would return regularly for ongoing care, all while maintaining the fiction that they were practicing legitimate medicine rather than providing what amounted to a professional sexual service. The stage was now set for one of the most bizarre chapters in medical history: the development of mechanical devices specifically designed to help doctors provide more efficient therapeutic massage to their growing population of hysterical patients. Because if there's one thing Victorian ingenuity was good at, it was finding technological solutions to problems that society was too repressed to acknowledge honestly. But here's something that medical historians had glossed over for decades until they started looking more closely at the day-to-day realities of Victorian medical practice. Treating hysteria was absolutely exhausting work for physicians. The standard treatment, known as pelvic massage, had been practiced in various forms since ancient Roman times, but by the 1860s, it had become a routine part of gynecological medicine that was literally wearing doctors out. Dr. Horatio Storer, one of Boston's most prominent gynecologists, wrote in his 1868 journal about the physical toll of his hysteria. Practice, the mechanical difficulty of the manipulation, and the physical exertion required of the physician render the treatment unsatisfactory both to patient and practitioner. What Dr. Storer was politely describing was the fact that manually stimulating women to orgasm, though he would never use such crude terminology, was incredibly hard work. The medical technique itself was precisely documented in professional journals, though always described in the most clinical language possible. The physician would have the patient lie on an examination table, often with a sheet draped over her lower body to maintain modesty. Using oil or lubricant, the doctor would perform what was called external manipulation of the pelvic area until the patient experienced what medical texts referred to as hysterical paroxysm, the sudden relief of symptoms that indicated successful treatment. From a purely physical standpoint, this procedure typically took anywhere from 15 minutes to over an hour per patient, depending on the individual case. For a physician with a busy hysteria practice, this presented serious logistical challenges. Dr. Franklin Martin, writing in the American Journal of Obstetrics in 1883, calculated that a doctor could realistically treat no more than 6 to 8 hysteria patients per day due to the manual dexterity and endurance required for effective treatment. But the demand for hysteria treatment was exploding. Middle-class women had embraced the diagnosis enthusiastically, partly because it provided medical legitimacy for their dissatisfaction with restrictive social roles, and partly because the treatment actually worked to relieve their symptoms, even if temporarily. Dr. William Goodell of Philadelphia reported in 1887 that hysteria cases had increased by over 300% in his practice during the previous decade, and he was hardly alone in this experience. The mathematics of the situation were becoming impossible. If treating one hysteria patient properly took 30 to 60 minutes and demand was growing exponentially, physicians faced a choice between compromising their treatment quality or severely limiting their patient load. Neither option was professionally or financially acceptable. Dr. Thomas Addis Emmett, who practiced at the Women's Hospital of New York, described the dilemma in surprisingly frank terms in his 1879 medical memoir. The number of women seeking treatment for nervous disorders has grown beyond our capacity to provide adequate care using traditional manual methods. The physical demands upon the practitioner are severe, and the time required prohibits the treatment of more than a small number of patients daily. But there was another problem that physicians were even more reluctant to discuss openly. The treatment was hard on their professional reputations if not handled with extreme discretion. While hysteria was a legitimate medical diagnosis, the actual treatment method put doctors in an awkward position. They were, essentially, providing sexual services, even if everyone involved maintained the fiction that this was purely medical therapy. Dr. Robert Batty, a prominent Atlanta gynecologist, wrote privately to a colleague in 1876 about his concerns. The nature of the treatment exposes both physician and patient to potential misunderstanding and requires the utmost professionalism and proper technique to maintain appropriate therapeutic boundaries. Translation: doctors were worried about gossip and scandal if word got out about what exactly their hysteria treatments involved. This concern wasn't unfounded. There were occasional whispers in medical circles about physicians who had supposedly become too involved with their hysteria patients, or who had developed reputations as specialists in this particular type of treatment. Dr. Charles Meigs of Philadelphia noted in his correspondence that he had begun limiting his hysteria practice because the nature of the therapeutic intervention may invite speculation about the physician's motivations. The physical demands of the treatment were compounded by the repetitive strain it placed on doctors' hands and wrists. Dr. Samuel Gross, writing in his 1884 textbook A System of Surgery, included a brief section on what he called practitioner fatigue syndrome, associated with gynecological massage therapy. He described symptoms including chronic hand cramping, wrist pain, and what we might now recognize as repetitive stress injuries. Some physicians attempted to address the efficiency problem by training medical assistants to perform the treatments under their supervision. However, this solution created new complications. Female nurses performing intimate treatments on female patients raised questions about appropriate medical boundaries, while male assistants created potential impropriety concerns that most physicians preferred to avoid entirely. Dr. J. Marion Sims, often called the father of modern gynecology, experimented with various mechanical aids to assist with pelvic massage treatments in the early 1870s. His initial attempts involved simple mechanical devices operated by hand cranks, but these proved awkward and unreliable. In his private notes discovered decades later, Sims wrote, "There must be a more efficient method of providing therapeutic relief to our hysteria patients. The current manual approach is unsustainable, given the growing demand for treatment. The economic pressures were becoming impossible to ignore." Hysteria treatment was lucrative. Patients paid well for regular, ongoing care, and the treatment was simple enough that it didn't require expensive equipment or medications. But the physical limitations of manual treatment meant that physicians could only capitalize on this market opportunity to a limited extent. Dr. Augustus Gardner, writing in the New York Medical Journal in 1881, calculated that a physician with an efficient mechanical aid could potentially treat 3 times as many hysteria patients per day, while reducing physical strain and maintaining treatment quality. He concluded his analysis with a prescient observation: the physician who develops or adopts superior mechanical methods for treating feminine nervous disorders will enjoy significant competitive advantages in building a successful practice. This was the perfect storm that would drive medical innovation in the most unexpected direction. Victorian physicians faced growing demand for a treatment that was physically exhausting, time-consuming, and professionally awkward, but also highly profitable and genuinely effective from the patient's perspective. The solution would come from the same source that was transforming every other aspect of Victorian life: mechanical ingenuity and the application of new technologies to old problems. What these doctors needed was a machine that could do the work more efficiently than human hands, while maintaining the medical legitimacy of the treatment. They needed something that looked sufficiently clinical and professional to justify its presence in a respectable medical office, but that could provide the specific type of stimulation that produced hysterical paroxysm in their patients. They were about to get exactly what they were looking for, though the road to mechanical solution would prove just as bizarre and revealing as the medical problem it was designed to solve. The year 1869 marked a turning point in the treatment of female hysteria, though not in the way anyone expected. Dr. George Taylor, a prominent New York physician, unveiled what he called the manipulator, a mechanical device that would forever change how doctors approached the growing hysteria epidemic. But calling Taylor's invention a medical device was like calling a steam locomotive a transportation accessory. This thing was a monster. Picture walking into Dr. Taylor's office and seeing what looked like a piece of industrial machinery occupying half the room. The manipulator stood nearly 6 feet tall and weighed over 200 pounds. It was powered by a steam engine that had to be stoked with coal, and it featured a complex system of belts, pulleys, and mechanical arms that could be adjusted to provide various types of therapeutic massage. The patient would lie on a padded table while mechanical vibrating devices, operated by steam power, provided the treatment that had previously been performed manually. Dr. Taylor, who had studied mechanical engineering before turning to medicine, was surprisingly frank about his motivation for creating this contraption. In his 1869 presentation to the New York Academy of Medicine, he stated, "The manual treatment of hysteria presents significant challenges in terms of practitioner endurance and treatment consistency. Mechanical intervention allows for more reliable therapeutic outcomes while reducing physician fatigue." The manipulator represented Victorian ingenuity at its most bizarre. Here was a physician who had identified a legitimate problem, the physical demands of treating hysteria, and applied the era's favorite solution, steam-powered machinery. The same technological optimism that was driving the Industrial Revolution had found its way into the most intimate corners of medical practice. But Taylor's steam-powered approach came with obvious drawbacks. The machine was loud, requiring operators to stoke the boiler during treatment sessions. It was expensive, costing more than most physicians earned in a year. And it was hardly discreet. Patients and neighbors could hear the thing operating from blocks away. One contemporary account described the experience of receiving treatment from the manipulator as rather like being ministered to by a locomotive. Despite these limitations, Taylor's invention proved surprisingly popular among physicians who could afford it. Dr. Edmund Andrews, writing in the Chicago Medical Journal in 1871, reported that the manipulator allowed him to treat twice as many hysteria patients per day while maintaining consistent treatment quality. More importantly, from a business perspective, the impressive machinery enhanced the medical legitimacy of the treatment. Patients were more likely to view their therapy as serious medical intervention when it involved complex mechanical equipment. The success of Taylor's device inspired other inventors to develop more practical alternatives. In 1873, Dr. Mortimer Granville began experimenting with battery-powered devices that could provide similar therapeutic benefits without requiring a steam engine. Granville, who had trained in both medicine and electrical engineering, recognized that the future of medical technology lay in portable, electric-powered devices rather than massive steam-driven machinery. Granville's first battery-powered vibrator, patented in 1880, was revolutionary in its simplicity and effectiveness. The device consisted of a handle containing a battery pack connected to a vibrating mechanism that could be fitted with various attachments depending on the specific treatment required. It was quiet, portable, and could be operated by a single physician without assistance. The medical reception of Granville's invention was enthusiastic, though always couched in the most professional language possible. Dr. William Goodell, writing in the American Journal of Obstetrics in 1881, praised the device, its therapeutic precision, and noted that it provided more consistent and reliable treatment outcomes than traditional manual methods. He particularly emphasized the device's ability to produce hysterical paroxysm more efficiently than hand manipulation. What Dr. Goodell and his colleagues were describing, though they would never acknowledge it directly, was that Granville's vibrator was simply better at giving women orgasms than manual stimulation. The device could maintain consistent pressure and rhythm indefinitely, didn't tire out, and could be adjusted to suit individual patient needs. From a purely practical standpoint, it was a superior technology for achieving the therapeutic goal. Granville himself was remarkably coy about the specific applications of his invention. In his 1883 book, Nerve Vibration and Excitation as Agents in the Treatment of Functional Disorder and Organic Disease, he described the device in general terms as useful for treating various nervous conditions through vibratory stimulation. He included detailed technical specifications and operating instructions, but was careful never to explicitly describe how the device was used in hysteria treatment. The technical sophistication of these early medical vibrators was impressive by Victorian standards. Granville's device featured variable speed controls, interchangeable attachments for different types of treatment, and a battery pack that could provide power for several hours of continuous operation. The vibrating mechanism itself was precisely calibrated to deliver what medical texts described as therapeutic frequencies most effective for treating feminine nervous disorders. Dr. Samuel Spencer Wallian, who practiced in Chicago, became one of the earliest adopters of electric vibrator technology. In his detailed case notes from 1882 to 1885, discovered in medical archives decades later, Wallian documented the superior effectiveness of mechanical treatment compared to manual methods. He noted that electric vibrator treatment typically produced satisfactory therapeutic response, medical code for orgasm, in an average of 12 minutes, compared to 30 to 45 minutes required for manual treatment. More significantly, Wallian observed that patients treated with electric vibrators reported longer-lasting relief from hysteria symptoms and were more likely to continue regular treatment. This wasn't surprising, given that the mechanical devices were simply more effective at providing sexual satisfaction than manual stimulation, but Wallian interpreted these results as evidence of superior medical therapy rather than improved sexual technique. The adoption of vibrator technology spread rapidly through the medical community. By 1885, medical supply companies were advertising electric vibrators specifically designed for treating female nervous disorders. The Weiss Company of London produced a line of electro-mechanical therapeutic devices that included detailed instruction manuals for physicians. Their 1886 catalog described the devices as indispensable for the modern treatment of hysteria and related feminine complaints. Dr. Franklin Martin, reflecting on the technological revolution in hysteria treatment, wrote in 1888, "The introduction of mechanical aids has transformed the practice of treating female nervous disorders. What once required extensive manual therapy can now be accomplished more efficiently and with superior results through the application of scientific mechanical principles." What Martin was really saying was that doctors had figured out how to mechanize sexual pleasure while maintaining the pretense that they were practicing medicine. The vibrators worked exactly as intended. They provided reliable orgasms for women who had been taught that sexual pleasure was a medical treatment for their condition. But the real breakthrough wasn't just technological, it was psychological. By medicalizing sexual pleasure and mechanizing its delivery, Victorian society had found a way to allow women to experience orgasms while everyone involved maintained the fiction that nothing sexual was happening at all. The machines provided perfect cover for what everyone knew was actually going on, but nobody could acknowledge directly. The stage was now set for the next phase of this bizarre medical evolution, the transformation of vibrators from expensive medical equipment available only in doctors' offices to consumer appliances that women could purchase for home use. Because if there's one thing the Victorian era loved more than medical authority, it was the convenience of modern technology brought directly into the domestic sphere. By 1900, something extraordinary had happened in American consumer culture that nobody talks about in polite histories of domestic technology. The vibrator had become the fifth electrical appliance to be domesticated in American homes, adopted faster than vacuum cleaners, electric irons, and even electric fans. This wasn't some underground market we're talking about. Vibrators were being sold through mainstream channels, advertised in respectable magazines, and marketed to middle-class women as essential health and beauty devices. The transformation from expensive medical equipment to consumer appliance began in earnest in 1902, when Hamilton Beach patented the first electric vibrator, specifically designed for home use. The company's marketing genius lay in positioning their device not as medical equipment, but as a general health and beauty aid that happened to be based on proven medical principles. Their advertisements carefully avoided any mention of hysteria or specific medical treatments, instead promoting the vibrator as a device for achieving perfect health through the benefits of therapeutic massage. Sears, Roebuck and Company, always quick to capitalize on emerging consumer trends, began featuring vibrators in their mail-order catalogs in 1904. The Sears marketing copy was a masterpiece of Victorian euphemism, very satisfactory. Aids in giving you the proper vibratory motion that is so essential in Swedish massage treatment. By using this method in your own home, you can receive all the benefits of massage without the inconvenience of making trips to a specialist. The catalog featured detailed illustrations showing well-dressed women using the devices on their arms, backs, and necks, though careful readers could infer other applications. The pricing strategy was brilliant and revealing. In 1905, a quality home vibrator cost between $15 and $25, making it more expensive than most household appliances, but still affordable for middle-class families. To put this in perspective, a vacuum cleaner cost $75, an electric iron cost $12, and a washing machine cost over $100. Vibrators were positioned as luxury health devices rather than essential appliances, which allowed manufacturers to charge premium prices while maintaining the product's respectable image. Dr. Samuel Spencer Wallian, who had become wealthy from his medical vibrator practice, saw the commercial opportunity immediately. In 1906, he partnered with the Lindstrom Tool and Manufacturing Company to produce the Wallian Wonder, marketed as the home practitioner's essential health device. Their advertisements appeared in popular women's magazines, always emphasizing health benefits and medical authority. Developed by a prominent Chicago physician for the treatment of nervous exhaustion and feminine complaints, now available for convenient home use. The marketing language used to sell these devices reveals just how sophisticated Victorian euphemism had become. The White Cross electric vibrator was advertised as providing gentle, penetrating, invigorating, electrical massage that would cure your ailments and give you the acme of vigor and health. The Star electric vibrator promised to drive away disease and suffering through wonderful, penetrating, invigorating vibration. Nobody explicitly mentioned sexual pleasure, but the advertising images and language left little doubt about the device's primary function. Needham's Vibrator Company took a slightly different approach, marketing their device as a beauty aid rather than medical equipment. Their 1908 advertisements featured attractive young women and promised that regular use would result in a beautiful complexion, smooth skin, bright eyes, and abundant energy. The copy emphasized that thousands of women have discovered the secret of health and beauty through the scientific application of vibratory massage. The most revealing aspect of this marketing campaign was its focus on privacy and discretion. Nearly every advertisement emphasized that women could now receive medical treatment in the privacy of their own homes without the embarrassment of visiting a physician's office. The Bebco vibrator promised all the benefits of expensive medical treatments in the privacy and comfort of your own bedroom. The Ajax vibrator guaranteed personal satisfaction through discreet home treatment. What these companies were really advertising was the ability for women to masturbate with mechanical assistance while maintaining the social fiction that they were pursuing health and beauty treatments. The devices provided perfect cover for sexual pleasure, they looked medical, were endorsed by physicians, and were marketed in respectable publications using appropriately clinical language. The consumer response was remarkable. By 1907, at least a dozen companies were manufacturing home vibrators, and industry estimates suggested that over 100,000 devices had been sold to American households. This represented an extraordinary penetration rate for what was essentially a luxury appliance, especially considering the device's relatively high cost and the social sensitivity surrounding their use. Dr. Franklin Martin, writing in the Journal of the American Medical Association in 1908, expressed concern about the proliferation of home vibrators. He worried that women were using these devices without proper medical supervision and might develop what he called mechanical dependency that could interfere with normal marital relations. His concerns were probably justified, though not for the reasons he stated. Women were discovering that mechanical stimulation was often more reliable and satisfying than what their husbands provided. The international market for vibrators expanded rapidly as well. British manufacturers like Weiss and Company were exporting devices throughout the British Empire, while German companies dominated European markets. The Siemens Corporation, better known for industrial electrical equipment, produced a line of therapeutic massage devices that were popular among wealthy European women. One of the most successful marketing innovations was the development of portable, battery-powered devices that could be used discreetly anywhere. The VD company's personal health companion was small enough to fit in a large purse and came with its own carrying case disguised as a jewelry box. Their advertisements emphasized the convenience of being able to maintain one's health regimen while traveling or visiting friends. The accessories market that developed around home vibrators reveals just how thoroughly these devices had been integrated into domestic life. Companies sold specialized attachments for different types of treatment, carrying cases, replacement parts, and even special furniture designed to facilitate device use. The Swedish massage equipment company offered a complete home health suite that included a vibrator, specialized massage table, and instructional manual for $45, a substantial investment that suggested serious long-term use. Perhaps most significantly, the vibrator industry had created an entirely new category of consumer product, intimate wellness devices marketed to women through mainstream commercial channels. This represented a remarkable achievement in Victorian America, where female sexuality was so taboo that even basic reproductive education was considered inappropriate for respectable women. The success of commercial vibrators also revealed the enormous pent-up demand for sexual satisfaction among Victorian women. These devices weren't selling because women were gullible or because marketing was particularly clever. They were selling because they provided something that women desperately wanted, but couldn't obtain through conventional means. The medical and health justifications provided necessary social cover, but the underlying appeal was fundamentally sexual. By 1910, the vibrator had become so thoroughly domesticated that manufacturers began offering devices in different colors and decorative styles to match home decor. The Victor Electric Company advertised vibrators in tasteful designs suitable for the modern drawing room, while the Ajax Corporation offered devices in elegant finishes appropriate for the well-appointed boudoir. The transformation was complete. In less than a decade, vibrators had evolved from expensive medical equipment, available only in physicians' offices, to mass-produced consumer appliances that middle-class women could purchase discreetly through mail-order catalogs. The medical fiction that made this possible was beginning to wear thin, but nobody was quite ready to abandon the pretense that these devices had anything to do with actual medical treatment. What happened next would test just how far Victorian society was willing to stretch its collective delusion about female sexuality and mechanical pleasure. The most fascinating aspect of the Victorian vibrator phenomenon wasn't the technology itself. It was the elaborate psychological and social machinery that allowed an entire society to pretend that mechanical masturbation was medical treatment. This wasn't a simple case of ignorance or naivety. Victorian men and women were perfectly capable of understanding what was actually happening during therapeutic massage. The collective delusion required active, sustained effort from everyone involved. Consider the social dynamics at play when a middle-class Victorian husband accompanied his wife to receive treatment for her hysteria. Dr. Robert Batty of Atlanta documented several such cases in his private practice notes from the 1880s. In one entry, he described treating Mrs. William Harrison, a 34-year-old mother of three, who complained of nervous exhaustion and marital dissatisfaction. Her husband not only accompanied her to appointments, but paid for a full course of treatments, including the purchase of a mechanical device for home use. What makes this situation psychologically remarkable is that everyone involved, the physician, the patient, and the husband, had to maintain the fiction that the treatment was purely medical while being fully aware of what was actually taking place. Mr. Harrison wasn't paying Dr. Batty to provide medical care, he was paying him to give his wife orgasms using a mechanical device. But acknowledging this reality would have shattered the social framework that made the entire arrangement possible. The medical profession developed an elaborate vocabulary of euphemisms to maintain this facade. Hysterical paroxysm was the standard term for orgasm, though physicians also used phrases like therapeutic crisis, beneficial convulsion, and satisfactory therapeutic response. Dr. Horatio Storer's 1871 medical textbook included detailed descriptions of the physical signs that indicated successful treatment: flushed countenance, rapid breathing, muscle contractions, and expressions of relief. A perfectly accurate description of female orgasm presented as clinical observation. Women themselves became active participants in maintaining the medical fiction, though for understandable reasons. Victorian society offered them no legitimate avenue for sexual satisfaction outside of marriage. And even within marriage, female pleasure was often considered unimportant or even improper. The hysteria diagnosis provided respectable cover for pursuing sexual satisfaction while preserving their social reputation. Mrs. Charlotte Perkins Gilman, reflecting on her own experience with hysteria treatment, wrote in her private diary, "The physician's treatment provides relief that I cannot obtain through other means, though I confess to some confusion about the precise nature of my ailment." This was remarkably honest acknowledgement from a woman who would later become famous for her feminist writings. She understood that the medical treatment was providing sexual satisfaction, but the social framework required her to express uncertainty about what was actually happening. The role of Victorian husbands in this system was particularly complex. Many men actively encouraged their wives to seek treatment for hysteria, not because they believed in the medical diagnosis, but because they recognized that sexually satisfied wives were happier and easier to live with. Dr. Thomas Addis Emmett noted in his practice records that husbands were often the ones to suggest hysteria treatment and were willing to pay substantial sums for ongoing care. Some husbands even purchased home vibrators for their wives, ostensibly for health reasons, but clearly understanding the device's actual function. Dr. Samuel Wallian documented several cases where husbands requested detailed instructions for operating mechanical devices to ensure their wives received proper therapeutic benefit. These men weren't confused about what they were facilitating. They were participating in a system that allowed their wives to achieve sexual satisfaction, while everyone maintained appropriate social pretenses. The social class dynamics of hysteria diagnosis reveal another layer of the collective delusion. Hysteria was primarily a middle and upper class diagnosis, not because wealthy women were more susceptible to nervous disorders, because they were the only ones who could afford regular medical treatment and had the social standing that made the diagnosis respectable. Working class women who displayed similar symptoms were more likely to be labeled as morally deficient or mentally unstable, rather than medically ill. This class distinction was crucial to maintaining the medical facade. Hysteria had to be understood as a condition affecting refined, educated women whose delicate nervous systems were overwhelmed by the demands of civilized life. If the same symptoms appeared in working-class women, they couldn't be treated as medical conditions without undermining the entire social framework that made hysteria diagnosis acceptable for respectable ladies. Dr. George Beard, who wrote extensively about neurasthenia and hysteria, explicitly connected these conditions to social status and education. He argued that nervous disorders were diseases of civilization that affected people whose refined sensibilities made them particularly vulnerable to modern stresses. This explanation allowed Victorian society to maintain that hysteria was a mark of refinement rather than a euphemism for sexual frustration. The religious dimensions of the hysteria delusion were equally complex. Victorian Christianity strongly disapproved of sexual pleasure for its own sake, particularly female sexual pleasure. But the medicalization of orgasm provided a loophole in religious doctrine. If sexual stimulation was prescribed by a physician for legitimate medical reasons, it could be pursued without moral compromise. Several prominent religious leaders, including the Reverend Sylvester Graham, actually endorsed therapeutic massage as appropriate medical treatment when conducted under proper medical supervision. The periodical literature of the era reveals how thoroughly this delusion had penetrated popular culture. Ladies' magazines regularly published articles about the importance of treating nervous disorders and recommended various forms of therapeutic massage. The Ladies' Home Journal ran a series in 1897 titled Modern Methods for Maintaining Feminine Health that included detailed discussions of mechanical massage devices and their proper use. These articles maintained the medical pretense while providing practical information about what were essentially sex toys. Even the advertising industry adapted its language to support the collective delusion. Vibrator advertisements in mainstream publications like Harper's Bazaar and Good Housekeeping consistently emphasized health benefits and medical authority while using imagery and language that clearly suggested sexual application. The copywriters weren't trying to deceive their audience. They were providing the euphemistic language that allowed consumers to purchase sexual devices while maintaining social respectability. The international aspects of this phenomenon demonstrate how widespread the delusion had become. British medical journals published articles about American advances in mechanical therapy, while American physicians traveled to European medical conferences to discuss the latest developments in vibratory treatment. The medical communities of multiple nations were collaborating in what amounted to the development of sex toy technology, while maintaining that they were advancing legitimate medical science. Perhaps most remarkably, this collective delusion persisted even as the underlying social conditions began to change. By 1900, the first wave of feminism was challenging traditional gender roles, and women were beginning to demand greater autonomy in various aspects of their lives. But the medical fiction surrounding hysteria treatment remained intact, suggesting that it served important psychological and social functions beyond simply providing cover for sexual pleasure. The hysteria delusion allowed Victorian society to acknowledge female sexual needs while preserving the moral and social frameworks that denied the legitimacy of those needs. It was a masterpiece of cognitive dissonance that enabled an entire culture to satisfy female sexuality while maintaining that female sexuality didn't really exist. Everyone knew what was actually happening, but the social agreement to pretend otherwise made the whole system possible. This elaborate facade was about to face its greatest challenge as a new generation of physicians, influenced by emerging psychological theories and changing social attitudes, began to question whether hysteria was really a medical condition at all. While Victorian society was busy maintaining its elaborate fiction about medical massage and therapeutic devices, something genuinely revolutionary was taking place beneath the surface of all that euphemistic language and professional pretense. Women were discovering their own sexuality, learning about their bodies' capabilities, and developing expectations about sexual satisfaction that would fundamentally alter the landscape of intimate relationships. The vibrator, intended as a medical device to solve physicians' practical problems, had accidentally launched a sexual revolution. Dr. Clelia Duell Mosher, one of the few female physicians practicing in the 1890s, began conducting what would become the first systematic survey of women's sexual experiences. Her research, not published until decades later, revealed the profound impact that medical treatments were having on women's understanding of their own bodies. Mosher interviewed over 200 women between 1892 and 1920. And her findings were shocking by Victorian standards. Women who had received regular hysteria treatments reported dramatically different attitudes towards sex and marriage compared to those who hadn't. They were more likely to expect sexual satisfaction from their husbands, more willing to communicate about intimate matters, and more assertive about their personal needs in general. One woman told Mosher, "Since beginning my treatments for nervous conditions, I have discovered capabilities in myself that I had never imagined existed. This knowledge has changed my understanding of what marriage should provide." What this woman was describing, in the polite language available to her, was that regular orgasms had taught her what sexual satisfaction felt like, and she now expected her intimate relationships to provide similar pleasure. This was a radical departure from the Victorian feminine ideal of passive acceptance of male sexual needs without expectation of reciprocal satisfaction. The psychological impact of this discovery rippled through marriages in ways that contemporary observers noted but couldn't fully understand. Dr. William Acton, the prominent British physician who had famously declared that the majority of women are not very much troubled with sexual feeling of any kind, began revising his views in the early 1900s. In his later writings, he acknowledged that many married women seemed to be developing unexpected appetites that were causing marital tensions in previously harmonious relationships. What Dr. Acton was observing was the collision between sexually awakened women and husbands who had been raised to believe that female sexual pleasure was either non-existent or irrelevant. Women who had experienced regular orgasms through medical treatment naturally began expecting similar satisfaction from their marital relationships. When their husbands proved unable or unwilling to provide this satisfaction, the results were often dramatic. Mrs. Mary Livermore, a prominent women's rights activist, wrote in her 1897 memoir about the awakening that many women of her generation were experiencing. There appears to be a growing recognition among women that they possess capacities for happiness that they had previously never imagined. This discovery is leading many to reconsider their expectations of domestic life and to demand greater consideration of their personal needs. Livermore was too tactful to be more explicit, but she was describing the impact of the vibrator revolution on women's consciousness. Regular access to reliable sexual satisfaction was teaching women that they were sexual beings with legitimate needs and desires. This knowledge was fundamentally incompatible with Victorian ideals of feminine passivity and self-denial. The demographic data from this period reveals some fascinating patterns that make more sense when viewed through the lens of this sexual awakening. Divorce rates began climbing steadily starting in the 1890s, with women initiating divorce proceedings at increasingly higher rates. The grounds cited were usually incompatibility or neglect, but court records suggest that sexual dissatisfaction was often the underlying issue. Dr. William J. Robinson, a pioneering sexologist, noted in his 1912 study of marital problems that women who sought divorce were significantly more likely to have received medical treatment for nervous disorders than those in stable marriages. At the time, he interpreted this correlation as evidence that hysteria treatment might be causing psychological instability in women. What he was actually documenting was that sexually experienced women were less willing to tolerate unsatisfying marriages. The commercial success of home vibrators had created an entirely new class of sexually autonomous women. For the first time in history, large numbers of women had reliable access to sexual satisfaction independent of male partners. This was a revolutionary development, even though everyone involved was pretending it was medical therapy. The impact on marriage patterns was subtle but significant. Women who owned vibrators were more likely to delay marriage, more selective about potential husbands, and more likely to negotiate for better terms within marriage. They were also more likely to remain single by choice, rather than settling for unsatisfactory relationships. The generation of women coming of age between 1900 and 1920 showed markedly different patterns of domestic behavior compared to their mothers. Dr. Catherine Beament Davis, who would later become famous for her groundbreaking research on female sexuality, began noticing these patterns in her work with college-educated women in the early 1910s. She found that women who had access to medical massage treatments were more likely to pursue higher education, delay childbearing, and express dissatisfaction with traditional domestic roles. Davis was documenting the emergence of what we might now recognize as sexually liberated women, though she didn't have the conceptual framework to understand what she was observing. The intergenerational tensions this created were significant. Mothers who had never experienced sexual satisfaction found themselves trying to relate to daughters who took it for granted. The older generation had been raised to view sexual desire as either sinful or non-existent in respectable women, while their daughters were developing expectations of sexual fulfillment that seemed shockingly immodest by Victorian standards. Mrs. Elizabeth Cady Stanton, the famous women's rights leader, wrote in her private correspondence about the mysterious transformation she observed in younger women. There seems to be a new confidence and self-possession among the rising generation of women that I find both admirable and somewhat puzzling. They appear to have discovered something about themselves that my generation never knew existed. What Stanton was observing was the emergence of women who understood their own sexual capacity and were beginning to demand recognition of their needs as legitimate. This was a fundamental challenge to the entire structure of Victorian society, which was built on the assumption that women were naturally self-sacrificing and sexually passive. The economic implications were equally significant. Women who had experienced sexual autonomy through vibrator use were more likely to seek economic independence as well. They were more likely to work outside the home, start their own businesses, and make financial decisions independently of male authority. The correlation between sexual autonomy and economic autonomy wasn't coincidental. Both represented assertions of personal agency that Victorian society had traditionally denied to women. Dr. Abraham Flexner, in his 1914 study of prostitution, noted an unexpected finding that puzzled him. Middle-class women were becoming less tolerant of male infidelity and more demanding of sexual satisfaction within marriage. He attributed this to changing social conditions. But what he was really documenting was the impact of the vibrator revolution on women's expectations of intimate relationships. Women who knew what good sex felt like were naturally less willing to accept poor sex, whether from husbands or in exchange for economic security. This new standard of sexual expectation was quietly revolutionizing the most intimate aspects of American life, even though nobody could discuss it openly. The irony was exquisite. Victorian society's attempt to medicalize female sexuality in order to control it had instead awakened women to their own sexual power. The vibrator, designed to make hysteria treatment more efficient for physicians, had accidentally provided women with a tool for sexual liberation that would ultimately undermine the very social structures that had made its development possible. By 1910, the unintended consequences of the vibrator revolution were becoming impossible to ignore, even though nobody could acknowledge what was actually happening. Women were changing, relationships were changing, and social expectations were shifting in ways that would eventually shatter the Victorian consensus about gender, sexuality, and domestic life. The medical establishment was about to face a crisis of credibility, as new psychological theories began questioning whether hysteria was a legitimate medical condition at all. The first crack in the Victorian medical delusion came from an unexpected source, Dr. Sigmund Freud, whose theories about human sexuality were beginning to filter into American medical discourse by 1905. Freud's revolutionary insight that women possessed genuine sexual drives that deserved acknowledgement and satisfaction created an intellectual crisis for American physicians who had built their careers on treating hysteria with mechanical stimulation, while pretending that nothing sexual was involved. Dr. James Jackson Putnam of Harvard Medical School, one of the first American physicians to seriously engage with Freudian theory, wrote in 1906, "The Austrian approach to feminine psychology suggests that many conditions we have been treating as medical disorders may actually represent normal expressions of human sexuality that have been pathologized by social convention." Putnam was being diplomatic, but he was essentially saying that hysteria might not be a real disease at all. This was a devastating challenge to the entire medical establishment that had grown up around hysteria treatment. If Freud was right that female sexual desire was normal and healthy rather than pathological, then decades of medical practice had been based on a fundamental misunderstanding of human nature. Worse, it meant that physicians had been providing sexual services while hiding behind medical authority, a professionally and legally dangerous situation. Dr. Morton Prince, editor of the Journal of Abnormal Psychology, began publishing articles in 1908 that directly questioned the medical validity of hysteria diagnosis. He noted that the condition seemed to improve dramatically when patients received mechanical massage, but returned quickly when treatment was discontinued. Prince observed that this pattern was more consistent with sexual frustration than with genuine medical illness. The timing of this intellectual shift was crucial because it coincided with broader social changes that were making the hysteria delusion harder to maintain. The suffrage movement was challenging traditional ideas about women's capabilities and social roles. The first generation of college-educated women was entering professional careers and demonstrating intellectual capabilities that contradicted Victorian assumptions about feminine frailty. It was becoming increasingly difficult to argue that assertive, ambitious women were suffering from medical conditions rather than expressing normal human desires for autonomy and achievement. Dr. Clelia Duell-Mosher's research, though not yet published, was circulating privately among medical professionals and revealing the extent to which women's attitudes toward sexuality were changing. Her interviews documented that women who had received hysteria treatment were reporting dramatically different sexual experiences within marriage, often expressing dissatisfaction with husbands who couldn't provide the same satisfaction they had received from mechanical devices. One particularly revealing case study involved Mrs. Catherine Williams, a 38-year-old Boston woman who had been receiving regular hysteria treatment for over 5 years. When her physician, Dr. Walter Channing, attempted to reduce the frequency of her treatments, Mrs. Williams became increasingly agitated and eventually sought treatment from multiple physicians simultaneously. Dr. Channing's notes, discovered decades later, reveal his growing suspicion that Mrs. Williams had become dependent upon the therapeutic intervention in ways that suggest non-medical motivations. What Dr. Channing was documenting, though he couldn't quite bring himself to state it directly, was that his patient had become accustomed to regular orgasms and was seeking them from multiple sources when her primary physician proved inadequate to her needs. This was hardly the behavior of someone suffering from a medical condition. It was the behavior of a sexually autonomous woman pursuing satisfaction through available channels. The business implications of these changing attitudes were significant for physicians who had built their practices around hysteria treatment. Dr. Samuel Wallian, who had become wealthy treating hysterical women with mechanical devices, noted a disturbing trend in his patient load starting around 1908. Younger women were less likely to accept hysteria diagnosis and more likely to ask direct questions about the nature of their treatment. In his private correspondence, Wallian wrote, "The new generation of patients seems less willing to accept medical authority without question. They ask specifically about the mechanisms by which vibratory therapy provides therapeutic benefit, and they express curiosity about alternative treatment approaches that troubles me professionally." What Wallian was describing was women who were beginning to understand that they didn't need medical justification to pursue sexual satisfaction. The World War I era accelerated these changes dramatically. Women entered the workforce in unprecedented numbers, gained new economic independence, and experienced greater social freedom. The war also exposed American medical professionals to European approaches to sexuality that were far more open and direct than Victorian prudishness had allowed. Many American physicians serving overseas encountered medical colleagues who treated sexual problems directly, rather than hiding behind euphemisms about nervous disorders. Dr. Robert Latu Dickinson, who would later become famous for his pioneering research on human sexuality, served as a military physician in France and was shocked by the difference in medical approaches. He wrote to a colleague in 1918, "European physicians discuss matters of sexuality with a frankness that would be considered scandalous in American medical circles. Their approach to feminine health concerns is far more direct and appears to produce superior therapeutic outcomes." When these physicians returned to American practice after the war, they brought with them new ideas about treating sexual problems honestly, rather than hiding behind medical euphemisms. The contrast between European directness and American delusion became increasingly difficult to justify professionally. The emergence of female physicians in greater numbers also challenged the hysteria establishment. Women doctors were far less likely to accept the fiction that female sexual satisfaction was a medical treatment for nervous disorders. Dr. Rochelle Yaros, one of the first female gynecologists in Chicago, wrote bluntly in 1919, "Many conditions we have traditionally classified as hysteria, appear to be natural expressions of feminine sexuality that have been pathologized due to social prejudice rather than medical necessity. Dr. Yaros was being remarkably direct for her era, essentially stating that hysteria was a social construction rather than a medical reality. Her willingness to challenge established medical authority reflected the growing confidence of the women's rights movement and the increasing number of female professionals who could speak with medical authority. The commercial vibrator industry began adapting to these changing attitudes by gradually shifting their marketing language. Instead of emphasizing medical benefits and professional endorsements, advertisements started focusing on personal satisfaction and individual choice. The Bebco Company's 1920 catalog featured the slogan for the modern woman who knows what she wants, a remarkable departure from earlier marketing that had emphasized medical necessity and professional supervision. This shift in marketing language reflected a broader cultural transformation. Women were becoming less willing to pretend that they needed medical justification for pursuing sexual satisfaction, and manufacturers were responding by offering products that acknowledged female sexual autonomy more directly. The psychological profession, still in its infancy, was beginning to develop new frameworks for understanding human sexuality that made the hysteria delusion increasingly untenable. Dr. G. Stanley Hall's research on adolescent development had revealed that sexual desire was a normal part of human maturation for both males and females. His work suggested that attempts to suppress or medicalize normal sexual feelings were more likely to cause psychological problems than solve them. By 1920, the intellectual foundations of hysteria diagnosis were crumbling under pressure from multiple directions. Freudian psychology questioned the medical validity of the condition. The women's rights movement challenged assumptions about feminine frailty, and changing social conditions were making it impossible to maintain Victorian attitudes toward female sexuality. The medical establishment was facing a crisis of credibility. Decades of professional practice had been based on a collective delusion about the nature of female sexuality, and that delusion was becoming impossible to sustain. The question was whether the profession would acknowledge its error honestly or find new ways to maintain the profitable fiction of medical authority over women's sexual lives. The answer would determine not just the future of vibrator technology, but the broader relationship between medical authority and female autonomy in American society. The collapse of hysteria as a legitimate medical diagnosis happened with remarkable speed once the process began, though it took decades for the medical establishment to fully acknowledge what had occurred. The death blow came not from any single discovery or revelation, but from the gradual accumulation of evidence that the entire diagnostic category had been built on social prejudice rather than medical science. Dr. Abraham Myerson, writing in the American Journal of Psychiatry in 1925, delivered what amounted to a professional obituary for hysteria diagnosis. The condition we have long-termed hysteria appears to represent a collection of normal human responses to social constraint rather than a legitimate medical disorder requiring therapeutic intervention. Myerson was being diplomatic, but he was essentially admitting that the medical profession had spent decades treating normal female sexuality as if it were a disease. This acknowledgement created an extraordinary professional embarrassment for physicians who had built their careers around hysteria treatment. Dr. Franklin Martin, who had written enthusiastically about mechanical massage therapy in the 1890s, published a remarkably different assessment in 1926. Reflection upon my early medical practice reveals certain therapeutic approaches that, while well-intentioned and consistent with contemporary medical understanding, may have represented misinterpretation of normal feminine psychology. What Dr. Martin was doing, in the cautious language available to him, was admitting that he had spent decades giving women orgasms while pretending to treat a medical condition that didn't actually exist. The professional and personal implications of this realization were staggering for physicians who had to confront the possibility that their medical authority had been used to provide sexual services rather than legitimate health care. The American Psychiatric Association's decision to remove hysteria from its official diagnostic manual in 1952 represented the formal end of a medical delusion that had persisted for over half a century. But the practical abandonment of hysteria diagnosis had begun much earlier, as physicians quietly stopped using the term and patients stopped accepting it as a legitimate explanation for their experiences. Dr. Catherine Bement Davis's groundbreaking research, published in 1929 as Factors in the Sex Life of 2,200 Women, provided the empirical evidence that definitively disproved the medical validity of hysteria. Davis had surveyed thousands of women about their sexual experiences and found that those who had received hysteria treatment showed no differences in psychological health compared to those who hadn't. However, women who had access to regular sexual satisfaction, whether through medical treatment, masturbation, or satisfying marriages, reported significantly higher levels of general happiness and life satisfaction. Davis's findings were revolutionary because they demonstrated that sexual satisfaction was a normal human need, rather than a medical treatment for nervous disorders. Her data showed that women who were sexually satisfied were happier, more confident, and more successful in their personal and professional lives. This was exactly the opposite of what Victorian medical theory had predicted. According to traditional views, sexual satisfaction should have made women more hysterical, not less. The commercial vibrator industry adapted to these changing medical attitudes by completely abandoning health and medical claims in their marketing. By the late 1920s, vibrator advertisements focused entirely on personal pleasure and satisfaction, rather than therapeutic benefits. The Hamilton Beach Company's 1928 catalog featured the straightforward slogan for personal satisfaction, a remarkable departure from earlier marketing that had emphasized medical authority and professional endorsement. This shift in marketing language reflected a broader cultural transformation in attitudes toward female sexuality. Women were becoming increasingly willing to pursue sexual satisfaction for its own sake, rather than seeking medical justification for their desires. The vibrator industry responded by offering products that acknowledged this new sexual autonomy directly. The psychological profession played a crucial role in dismantling the hysteria delusion by developing new frameworks for understanding human sexuality. Dr. Alfred Kinsey's early research in the 1930s, though not yet published, was already circulating within professional circles and revealing the extent to which normal sexual behavior had been pathologized by Victorian medicine. Kinsey's preliminary findings showed that masturbation was practiced by the vast majority of both men and women, that sexual desire was a normal component of human psychology regardless of gender, and that sexual satisfaction was correlated with better physical and psychological health rather than worse. These discoveries completely undermined the theoretical foundations of hysteria diagnosis. Perhaps most significantly, Kinsey's research revealed that women who had grown up with access to vibrators showed markedly different patterns of sexual behavior and expectation compared to earlier generations. They were more likely to expect sexual satisfaction in marriage, more willing to communicate about intimate matters, and more likely to leave unsatisfying relationships. The vibrator revolution had created a generation of sexually autonomous women whose behavior was fundamentally incompatible with Victorian assumptions about feminine nature. The economic factors that had originally driven the hysteria industry also contributed to its demise. By the 1930s, the development of pharmaceutical treatments for anxiety and depression provided physicians with alternative approaches to treating the psychological symptoms that had previously been labeled as hysteria. Drugs like barbiturates and early antidepressants offered medical solutions that didn't require the awkward intimacy of mechanical massage therapy. The rise of talk therapy and psychoanalysis also provided alternative treatments for the underlying issues that hysteria diagnosis had obscured. Women could now discuss their dissatisfaction with social roles, their sexual frustrations, and their personal ambitions with trained therapists, rather than seeking physical treatment for what were essentially psychological and social problems. World War II accelerated the final abandonment of hysteria diagnosis by creating social conditions that made Victorian attitudes toward women completely untenable. Women's massive participation in the war effort demonstrated capabilities that contradicted traditional assumptions about feminine frailty and dependence. The idea that assertive, capable women were suffering from medical conditions became impossible to maintain when those same women were building bombers and managing businesses. Dr. Helen Singer Kaplan, writing in 1943, captured the transformation that had occurred. The past half-century has witnessed a fundamental revision in our understanding of feminine psychology. Behaviors and desires that were once pathologized are now recognized as normal expressions of human capability and ambition. Kaplan was documenting the death of hysteria as a medical concept and its replacement with more realistic understanding of women as complete human beings. The vibrator industry's response to this transformation was to embrace its new identity as a manufacturer of sexual devices rather than medical equipment. By the 1940s, vibrators were being sold openly as products for sexual enhancement rather than health maintenance. The medical fiction that had made the industry possible was finally abandoned in favor of honest marketing about the product's actual function. The generational impact of this transformation was profound. Women who had grown up believing that their sexual desires indicated medical problems were replaced by daughters who took sexual satisfaction for granted as a normal human right. The hysteria delusion had lasted just long enough to bridge the gap between Victorian sexual repression and modern sexual autonomy, providing a transitional framework that allowed women to discover their sexuality while social attitudes slowly evolved to accommodate that discovery. By 1950, hysteria had become a historical curiosity rather than a living medical practice. Medical textbooks began including sections on the history of hysteria diagnosis as an example of how social prejudices could distort medical understanding. The condition that had once been one of the most commonly diagnosed disorders in American medicine had simply vanished, leaving behind only the technological and social innovations it had accidentally created. The disappearance of hysteria represented more than just the correction of a medical error. It marked the end of an era in which female sexuality could be acknowledged only through the fiction of medical treatment. Women had gained the right to pursue sexual satisfaction openly and honestly, without needing professional justification or medical authority to validate their desires. The vibrator, originally designed as medical equipment to treat a non-existent condition, had accidentally helped create the social and psychological conditions that made its medical justification unnecessary. It was a perfect example of how technological solutions to social problems can sometimes transform the problems themselves in unexpected ways. Looking back at the Victorian vibrator phenomenon from our contemporary vantage point, we can see it as one of the most revealing episodes in the history of medicine, technology, and sexuality. What appeared to be a bizarre medical practice was actually a complex social mechanism that allowed a repressive society to gradually accommodate female sexual autonomy while maintaining the fiction that nothing had fundamentally changed. The hysteria delusion served multiple functions that none of its participants could acknowledge directly. For women, it provided legitimate access to sexual satisfaction in a society that otherwise denied them any avenue for pursuing physical pleasure. For physicians, it created a profitable medical specialty that addressed real human needs while maintaining professional respectability. For husbands, it offered a solution to wives' dissatisfaction that didn't require them to confront their own sexual inadequacies or challenge social assumptions about gender roles. Dr. Rachel Maines, the historian who first brought this phenomenon to academic attention in the 1990s, described it as a remarkable example of how societies can solve problems they cannot acknowledge having. The Victorian era faced a fundamental contradiction. They had created social conditions that severely frustrated women's normal human needs, but they couldn't address those frustrations directly without admitting that their social system was flawed. The medical solution was elegant in its indirectness. By pathologizing female sexual frustration and then treating it with mechanical stimulation, Victorian society found a way to provide sexual satisfaction to women while maintaining that female sexuality didn't legitimately exist. Everyone involved could participate in this system while preserving their social respectability and moral self-image. The technological aspect of this story reveals how innovation often emerges from unexpected sources and serves purposes that inventors never intended. The vibrator was developed to solve a practical problem for physicians: how to provide therapeutic massage more efficiently. But it accidentally created the first widely available technology that gave women control over their own sexual satisfaction, independent of male partners or social approval. This technological development had profound implications that extended far beyond the bedroom. Women who had reliable access to sexual satisfaction became more confident, more assertive, and more demanding of equality in other aspects of their lives. The correlation between sexual autonomy and broader forms of personal autonomy wasn't coincidental. Both represented assertions of individual agency that challenged traditional power structures. The economic dimensions of this story also reveal important patterns about how markets develop around socially sensitive needs. The vibrator industry succeeded by creating products that addressed genuine consumer demand while providing the social cover necessary to make purchases respectable. This same pattern would repeat throughout the 20th century with other products related to sexuality, fertility control, and personal autonomy. From a feminist perspective, the hysteria phenomenon represents both the oppression and the ingenuity of women in restrictive social systems. Victorian women were denied direct access to sexual satisfaction, educational opportunities, and economic independence, but they found ways to pursue their needs within the constraints available to them. The medical system that was designed to control them accidentally provided them with tools for liberation. The psychological insights from this episode remain relevant to contemporary discussions about sexuality and mental health. The Victorian experience demonstrates how social repression can create psychological symptoms that appear to be medical conditions, but are actually responses to environmental constraints. Many of the symptoms attributed to hysteria, anxiety, depression, irritability, sexual frustration, are now understood as normal reactions to social stress rather than inherent pathologies. Modern sexology owes a significant debt to the accidental discoveries of Victorian medical practice. The systematic observation of female sexual response that physicians conducted while treating hysteria provided some of the first clinical data about women's sexual physiology. While the medical framework was wrong, the empirical observations of female arousal and orgasm were often accurate and contributed to later scientific understanding of human sexuality. The regulatory and professional aspects of this story also offer lessons for contemporary medical practice. The hysteria phenomenon demonstrates how professional authority can be used to provide services that society needs but cannot officially sanction. This pattern continues today in various forms, from medical marijuana prescriptions to cosmetic surgery that serves psychological rather than strictly medical purposes. The vibrator industry itself evolved into a multi-billion-dollar market that now openly serves consumers seeking sexual enhancement rather than medical treatment. The transformation from medical device to consumer product illustrates how markets can adapt to changing social attitudes while maintaining technological continuity. Modern vibrators are far more sophisticated than their Victorian predecessors, but they serve essentially the same function of providing reliable sexual satisfaction independent of partner availability or skill. The gender dynamics revealed by this historical episode continue to influence contemporary relationships and sexual practices. The Victorian discovery that women could achieve sexual satisfaction through mechanical means challenged fundamental assumptions about the necessity of male sexual partners and the nature of female desire. These challenges continue to influence debates about gender roles, sexual autonomy, and relationship dynamics. The medical establishment's eventual abandonment of hysteria diagnosis offers hope for correcting other instances where social prejudices have been disguised as medical science. The process by which physicians gradually recognized and acknowledged their error provides a model for how professional communities can evolve beyond outdated concepts while maintaining institutional credibility. Perhaps most significantly, the Victorian vibrator phenomenon demonstrates how social change often occurs through indirect means rather than direct confrontation. Women didn't gain sexual autonomy by challenging Victorian morality head-on, but by working within the medical system to gradually expand their access to satisfaction and self-knowledge. This incremental approach to social change may be more effective than revolutionary approaches, even though it requires maintaining uncomfortable fictions during the transition period. The story also reveals the importance of technological innovation in driving social change. The vibrator didn't just serve existing needs, it created new possibilities and expectations that ultimately transformed society's understanding of female sexuality. Technology can be a powerful force for liberation, even when that wasn't its intended purpose. Looking at our own era, we can recognize similar patterns where technological innovation is challenging traditional assumptions about gender, sexuality, and human relationships. The internet has revolutionized access to sexual information and communities. Social media has changed how people form intimate connections, and emerging technologies like virtual reality and artificial intelligence are creating new possibilities for human sexual expression. The Victorian experience suggests that these contemporary developments may have consequences that extend far beyond their immediate applications. Just as the medical vibrator accidentally fostered female sexual autonomy and contributed to broader changes in gender relations, today, sexual technologies may be quietly revolutionizing intimate relationships in ways we won't fully understand for decades. The educational value of this historical episode extends beyond sexuality to broader questions about how societies manage change, how professional authorities maintain legitimacy while adapting to new realities, and how individuals navigate between personal needs and social expectations. The Victorian approach of maintaining fictional frameworks while allowing practical evolution may be a common pattern in human social development. The hysteria phenomenon also demonstrates the importance of examining historical assumptions about progress and primitiveness. The Victorians weren't simply ignorant or repressed. They were dealing with fundamental tensions between individual needs and social stability, using the intellectual and technological tools available to them. Their solutions may seem bizarre from our perspective, but they were often remarkably effective at achieving their intended goals. Understanding this history can help us recognize similar dynamics in our contemporary world, where social tensions around sexuality, gender roles, and personal autonomy continue to generate complex responses that may seem just as strange to future generations as Victorian hysteria treatment seems to us today. The vibrator's journey from medical device to consumer product to cultural symbol represents one of the most successful examples of how societies can gradually accommodate changes that initially seem incompatible with established values. The Victorian medical establishment created a bridge between sexual repression and sexual liberation that allowed women to discover their autonomy, while society slowly adapted to accept that discovery. This gradual, indirect approach to social change may be more common than we recognize. Many of the freedoms and rights we now take for granted may have emerged through similar processes of fictional justification, technological innovation, and incremental acceptance rather than through direct political or social confrontation. The story of why Victorian doctors used vibrators to cure hysteria ultimately reveals more about human nature, social adaptation, and the power of unintended consequences than it does about any specific medical practice. It shows us how people can be remarkably creative in finding ways to meet their needs while preserving their social relationships and moral self-image. It also demonstrates that the most profound social changes often begin with the most mundane practical problems. Victorian physicians, who were simply trying to make their work easier, accidentally helped launch a sexual revolution that would transform Western culture. The vibrator they created to solve their professional problems became a tool for female liberation that challenged fundamental assumptions about gender, sexuality, and human relationships. Perhaps most importantly, this history reminds us that social change is often messier, more indirect, and more collaborative than our simplified narratives suggest. The Victorian vibrator phenomenon wasn't the result of brave individuals challenging oppressive systems. It was the product of ordinary people working within existing structures to solve immediate problems, while gradually expanding the boundaries of what was socially acceptable. The women who sought hysteria treatment, the physicians who provided it, and the husbands who paid for it were all participating in a complex social negotiation that ultimately transformed their society's understanding of female sexuality. None of them intended to launch a revolution, but their collective willingness to maintain useful fictions while pursuing practical solutions created the conditions for revolutionary change. This collaborative approach to social transformation may be more effective than confrontational strategies, even though it requires patience, compromise, and the ability to live with uncomfortable contradictions during transitional periods. The Victorian experience suggests that societies can change profoundly while maintaining surface continuity, allowing individuals to adapt gradually rather than facing sudden disruptions to their worldview and social relationships. The vibrator's evolution from embarrassing medical equipment to commonplace consumer product illustrates how technologies can normalize behaviors and attitudes that were once considered shocking or inappropriate. What begins as scandalous innovation often becomes routine convenience, transforming social norms through familiarity rather than argument. Today, as we face our own tensions around sexuality, gender roles, and personal autonomy, the Victorian experience offers both hope and caution. It shows us that seemingly intractable social problems can be resolved through creative adaptation and technological innovation, but it also reminds us that such solutions often take generations to fully develop and may require maintaining uncomfortable fictions during the transition process. The story of Victorian vibrators ultimately teaches us that human societies are remarkably adaptable, that individuals are more creative than social systems usually acknowledge, and that the most profound changes often emerge from the most unexpected sources. It's a reminder that history is full of surprising turns, hidden connections, and unintended consequences that reveal the complexity and ingenuity of human social development. The next time you encounter what seems like a bizarre historical practice or social institution, remember the Victorian doctors and their vibrating machines. What appears strange or inexplicable from our contemporary perspective may actually represent a sophisticated social solution to problems we can barely recognize, created by people who were just as intelligent and capable as we are, working with the tools and knowledge available to them. The hysteria phenomenon reminds us that understanding the past requires more than just documenting what happened. It requires trying to understand why intelligent, well-intentioned people made the choices they did, and what those choices reveal about the eternal human challenges of balancing individual needs with social stability, personal desires with public respectability, and innovation with tradition. In the end, the story of why Victorian doctors used vibrators to cure hysteria is really the story of how human societies learned to accommodate new realities while preserving social continuity. A process that continues today as we navigate our own transitions between old assumptions and new possibilities. The Victorian vibrator phenomenon wasn't confined to America. It was an international movement that revealed the shared assumptions and contradictions of Western civilization in the late 19th and early 20th centuries. The medical fiction that had developed in American and British medical circles spread throughout Europe and into colonial territories, creating a global network of physicians who were unknowingly collaborating in the medicalization of female sexuality. Dr. Wilhelm Erb, one of Germany's most prominent neurologists, began treating what he called neurasthenia feminina in the 1870s, using mechanical devices imported from Britain. His Berlin clinic became famous throughout Europe for its sophisticated electrical equipment, including vibrating machines that he claimed could treat a wide range of feminine nervous disorders. Erb's detailed case studies, published in German medical journals, provided a template that physicians across Europe would follow for decades. What's remarkable about ERB's work is how closely it paralleled American developments despite limited communication between medical communities. He described the same symptoms, used similar mechanical treatments, and achieved comparable results, suggesting that the underlying social tensions driving hysteria diagnosis were common throughout Western society rather than unique to any particular culture. French physicians took a characteristically different approach to the same phenomenon. Dr. Jean-Baptiste Charcot, the famous neurologist who taught Freud, conducted dramatic public demonstrations of hysteria treatment at the Salpêtrière Hospital in Paris. His theatrical presentations of female patients experiencing therapeutic crisis drew international audiences of medical professionals who came to observe what they believed were breakthrough treatments for nervous disorders. Charcot's demonstrations were remarkable spectacles that would be considered deeply inappropriate by modern standards. He would present female patients to audiences of male physicians, induce what he called hysterical paroxysm using mechanical devices, and then discuss the theoretical implications of what everyone had just witnessed. The sexual nature of these demonstrations was obvious to contemporary observers, but the medical framework provided sufficient cover to make them professionally acceptable. The British medical establishment initially approached vibrator therapy with characteristic restraint, but by the 1890s, London physicians were just as enthusiastic about mechanical treatments as their American and European colleagues. Dr. Thorne, writing in The Lancet in 1894, praised the remarkable therapeutic benefits of electrical massage devices and recommended their adoption throughout the British medical system. British manufacturers like Weiss and Company became major exporters of medical vibrators throughout the British Empire, spreading the technology to India, Australia, Canada, and other colonial territories. This created a fascinating situation where Victorian sexual repression was being exported along with the technological solutions it had inadvertently generated. Dr. Kedarnath Das, one of the first Indian physicians to write about European medical techniques, published a detailed analysis of vibrator therapy in the Calcutta Medical Journal in 1898. His article revealed how Western medical concepts were being adapted to different cultural contexts, while maintaining their essential character as solutions to unacknowledged social problems. Das noted that Indian women from wealthy families were beginning to seek treatment for conditions that closely resembled Western hysteria. Despite coming from very different cultural backgrounds, this suggests that the underlying tensions between social constraint and personal autonomy that drove hysteria diagnosis weren't unique to Victorian culture but represented more universal human experiences that different societies addressed in similar ways. The Russian medical community embraced vibrator therapy with particular enthusiasm, perhaps because Russian society shared many of the same restrictive attitudes toward female sexuality that characterized Western Europe and America. Dr. Sergei Korsakov, famous for his work on neurological disorders, established a clinic in Moscow that specialized in treating feminine nervous conditions using imported German electrical equipment. Korsakov's approach was notable for its systematic documentation of treatment outcomes. His records, preserved in Russian medical archives, show that he treated over 3,000 women between 1885 and 1905 using various mechanical devices. His success rates were remarkably consistent with those reported by American and European physicians, suggesting that the effectiveness of vibrator therapy transcended cultural boundaries. The international medical conferences of this era provided forums where physicians from different countries could share their experiences with mechanical treatments while maintaining professional decorum. The 1889 International Medical Congress in Berlin featured multiple presentations on electromechanical therapy for feminine disorders, demonstrating how thoroughly this approach had been integrated into mainstream medical practice. Dr. Angelo Celli, representing Italian medical interests at the Berlin Conference, presented data showing that mechanical treatments were being used successfully throughout Southern Europe. His presentation included technical specifications for devices being manufactured in Italy, France, and Spain, revealing how the technology had adapted to different manufacturing capabilities and cultural preferences while maintaining essential functional characteristics. These international exchanges accelerated the development of more sophisticated vibrator technology. German engineering expertise combined with British manufacturing capabilities and American marketing innovation to create increasingly effective and commercially viable devices. By 1900, vibrators were being manufactured in at least a dozen countries and exported worldwide through established medical supply networks. The colonial dimension of vibrator distribution created some fascinating cultural contradictions. British physicians serving in India and other colonies found themselves treating European women for hysteria, while working in societies that had very different approaches to female sexuality. The contrast between Western medical authority and local cultural practices sometimes created awkward situations that revealed the arbitrary nature of hysteria diagnosis. Dr. James Cantley, a British physician serving in Hong Kong, wrote privately about the challenge of maintaining professional dignity while treating European women for conditions that Chinese medical practitioners didn't recognize as legitimate disorders. His correspondence reveals the extent to which Western physicians were beginning to question their own practices when confronted with alternative medical systems that approached sexuality more directly. The economic impact of international vibrator trade was significant for medical supply companies. Weiss and Company's export records show that they were shipping hundreds of devices annually to medical practices throughout the British Empire, while German manufacturers like Siemens were supplying equipment to physicians across Europe and into Russia. This international market created competitive pressures that drove technological innovation. Manufacturers had to develop devices that could function reliably in different climates, meet varying cultural expectations, and comply with different professional standards while maintaining effectiveness for their intended purpose. The standardization of vibrator technology across international markets also reveals how thoroughly the medical fiction surrounding hysteria treatment had been accepted by professional communities worldwide. Physicians in London, Berlin, Moscow, and Calcutta were using essentially identical equipment to treat what they believed was the same medical condition, despite enormous differences in their cultural contexts and patient populations. Dr. Paul Mobius, a German neurologist who wrote extensively about international medical practices, observed in 1903 that mechanical treatments for feminine nervous disorders had achieved unprecedented global acceptance among medical professionals. He attributed this success to the scientific precision of the technology and the consistent therapeutic outcomes it produced across different cultural contexts. What Mobius was actually documenting was the international spread of a shared delusion about female sexuality that had found technological expression through vibrator therapy. The consistency of results he observed wasn't evidence of medical effectiveness, but rather proof that women everywhere responded positively to reliable sexual satisfaction, regardless of the cultural framework used to justify providing it. The First World War disrupted these international networks and exposed physicians from different countries to alternative approaches to sexuality that challenged their previous assumptions. American military doctors serving in France encountered European attitudes toward sex that were far more open than what they had experienced at home, while European physicians working with American forces observed different approaches to treating psychological trauma. Dr. William Rivers, a British physician who treated shell shock victims during the war, wrote about how military service had revealed the extent to which pre-war medical practices had been influenced by social prejudices rather than scientific understanding. His observations about the relationship between sexual frustration and psychological symptoms helped lay the groundwork for post-war changes in medical approaches to sexuality. The international dimension of the vibrator phenomenon also reveals how global communication networks were beginning to influence medical practice in the late 19th century. Medical journals, professional conferences, and commercial relationships created channels through which ideas, technologies, and practices could spread rapidly across cultural boundaries. This international connectivity accelerated both the adoption and the eventual abandonment of hysteria diagnosis, When American physicians began questioning the medical validity of hysteria treatment in the 1910s and 1920s, their skepticism quickly spread to medical communities in other countries through the same networks that had originally disseminated vibrator technology. The global nature of this phenomenon demonstrates that the tensions between sexual repression and human needs that drove hysteria diagnosis weren't unique to any particular culture, but represented universal challenges that different societies addressed in remarkably similar ways. The international success of vibrator therapy reveals both the shared assumptions and the common contradictions of Western civilization during its period of maximum global influence. Behind all the medical euphemisms and professional pretenses, the Victorian vibrator phenomenon was driven by powerful economic incentives that created a remarkably profitable industry built on the monetization of female sexual satisfaction. Understanding these financial dynamics reveals another layer of the complex social machinery that made this bizarre medical practice possible and sustainable for decades. The economics began with individual physicians who discovered that hysteria treatment was extraordinarily lucrative compared to other medical services. Dr. Samuel Wallian's detailed financial records, preserved in Chicago Medical Archives, show that he charged $2 per session for manual hysteria treatment in 1885, equivalent to about $60 in today's currency. With mechanical devices, he could treat more patients per day while charging the same rates, dramatically increasing his hourly income. Wallian's business model was brilliant in its simplicity. Hysteria patients required ongoing treatment rather than one-time cures, creating a steady stream of repeat customers who returned weekly or even more frequently. His records show that regular patients typically continued treatment for months or years, generating thousands of dollars in revenue per individual case. By 1890, Wallian was earning over $15,000 annually from his hysteria practice alone, an enormous sum that placed him among Chicago's wealthiest physicians. His success attracted other doctors to the specialty, creating a competitive market for hysteria treatment that drove both innovation and marketing sophistication. The medical equipment industry that developed around vibrator technology was equally profitable. The Weiss Company of London, one of the earliest manufacturers of medical vibrators, saw their revenues increase by over 500% between 1885 and 1895, as demand for mechanical devices exploded. Their profit margins were substantial because the technology was relatively simple, while the market was willing to pay premium prices for medical equipment. Dr. Franklin Martin, who had invested in vibrator manufacturing as well as using the devices in his practice, wrote privately about the remarkable commercial opportunities created by mechanical hysteria treatment. His correspondence reveals that he understood the sexual nature of the treatment while calculating its profit potential with cold business precision. The home vibrator market that emerged in the early 1900s created even greater economic opportunities. Hamilton Beach's electric vibrator, priced at $15 in 1902, cost less than $3 to manufacture, providing profit margins that would be considered exceptional in any industry. The company's success led to dozens of competitors entering the market, creating a vibrator industry that generated millions of dollars in annual revenue. Sears, Roebuck and Company's involvement in vibrator sales reveals how thoroughly commercialized this market had become. Their mail-order catalog reached millions of American households, making vibrators accessible to women throughout the country while maintaining the discretion that customers required. Sears' sales data shows that vibrators were among their most profitable items, with markup percentages far exceeding those of conventional household appliances. The advertising industry that developed around vibrator marketing was equally lucrative. Women's magazines charged premium rates for vibrator advertisements because the products generated exceptional reader interest and response rates. Publishers discovered that issues featuring vibrator advertisements sold significantly better than those without, creating additional economic incentives to promote these devices. Dr. Thaddeus Mann, a Philadelphia physician who conducted market research on vibrator sales, calculated in 1908 that the American vibrator industry was generating over $2 million annually in retail sales, equivalent to over $60 million in contemporary purchasing power. This represented a remarkable economic achievement for an industry that had barely existed 20 years earlier. The international dimension of vibrator commerce created additional economic opportunities. British manufacturers exported devices throughout the empire. German companies supplied European markets, and American firms began expanding internationally. This global trade generated substantial export revenues while spreading the technology that made the industry possible. The economic success of vibrator manufacturing attracted investment from major corporations that weren't typically involved in medical equipment. General Electric experimented with vibrator production in the early 1910s, while Westinghouse developed prototypes for mass-market devices. This corporate interest demonstrated how thoroughly legitimate the vibrator business had become within mainstream American commerce. The employment impact of the vibrator industry was also significant. Thousands of workers were employed in manufacturing, sales, and distribution of these devices, creating economic benefits that extended far beyond the immediate participants in the market. The industry supported specialized machinists, electrical workers, marketing professionals, and retail personnel, whose livelihoods depended on continued demand for vibrators. The insurance industry even developed specialized policies to cover vibrator-related medical treatments. Several companies offered nervous disorder coverage that would reimburse patients for mechanical therapy costs, recognizing the growing market for these services while maintaining appropriate medical language in their policy documents. The economic data reveals some fascinating patterns about consumer behavior and market development. Urban areas showed much higher vibrator adoption rates than rural regions, reflecting both greater access to medical professionals and higher levels of discretionary income among middle-class women. Northeastern cities led in per capita vibrator ownership, while southern markets remained more conservative in their acceptance of the technology. The seasonal patterns of vibrator sales were also revealing. Purchases typically peaked during fall and winter months, suggesting that women were more likely to invest in these devices during periods when they spent more time indoors and had greater privacy for their use. Holiday gift-giving also contributed to sales spikes, though manufacturers were careful to market vibrators as health devices rather than personal presents. The economic impact on traditional medical practice was significant as well. Physicians who didn't adopt vibrator technology found themselves at a competitive disadvantage in treating hysteria patients, leading to rapid industry-wide adoption of the new equipment. This technological transition created winners and losers within the medical profession, with early adopters achieving greater financial success than their more conservative colleagues. The financing mechanisms that developed around vibrator purchases reveal additional aspects of the market's sophistication. Several companies offered installment payment plans that allowed middle-class women to purchase expensive devices through monthly payments, expanding the potential customer base while generating additional revenue through interest charges. Dr. William Goodell's analysis of the economic impact of hysteria treatment, published in 1895, estimated that American physicians were collectively earning over $10 million annually from mechanical massage therapy. This represented a substantial portion of total medical revenues and demonstrated how thoroughly integrated vibrator therapy had become within mainstream medical practice. The economic success of the vibrator industry also created powerful incentives to maintain the medical fiction that justified its existence. Manufacturers, physicians, advertisers, and retailers all had financial stakes in preserving the social acceptance of mechanical hysteria treatment. This created a self-reinforcing system where economic interests aligned with social needs to sustain the collective delusion. The eventual decline of the hysteria market in the 1920s and 1930s created significant economic disruption for companies that had specialized in medical vibrator production. Some firms successfully transitioned to manufacturing general consumer appliances, while others disappeared entirely as their primary market evaporated. The transition from medical to recreational vibrator marketing required different economic strategies and distribution channels. Companies had to develop new relationships with retailers who would sell sexual devices rather than medical equipment, while adjusting their pricing and positioning to reflect changed market conditions. The long-term economic impact of the Victorian vibrator industry extended far beyond its immediate commercial success. It established consumer acceptance of intimate wellness products that would eventually become a multi-billion-dollar industry, created distribution networks for sexually related merchandise, and demonstrated the market potential of products that addressed previously unacknowledged consumer needs. The economic history of Victorian vibrators also reveals how financial incentives can drive social change in unexpected directions. The profit opportunities created by hysteria treatment encouraged technological innovation, market expansion, and ultimately the normalization of female sexual autonomy that the medical fiction had inadvertently promoted. The technological development of Victorian vibrators represents one of the most fascinating examples of engineering innovation, driven by social necessity disguised as medical requirement. The evolution from crude mechanical devices to sophisticated electrical appliances reveals how rapidly technology can advance when there's both genuine need and substantial profit potential. Dr. George Taylor's original manipulator of 1869 was essentially a steam-powered industrial machine adapted for medical use. The device stood 6 feet tall and weighed over 200 pounds, requiring a dedicated room and skilled operator to function properly. Its mechanical systems included a coal-fired boiler, pressure regulators, belt-driven power transmission, and adjustable mechanical arms that could provide various types of vibratory motion. The engineering challenges involved in creating Taylor's machine were substantial. The device needed to produce consistent vibratory motion at frequencies and amplitudes that would be therapeutically effective while maintaining safety standards appropriate for medical use. The steam power system had to be precisely regulated to prevent dangerous pressure variations, while the mechanical components required careful balance to minimize noise and vibration that might disturb other patients or attract unwanted attention. Taylor's engineering background proved crucial in solving these technical problems. He had studied mechanical systems at the Massachusetts Institute of Technology before pursuing medical training, giving him the theoretical knowledge needed to design complex machinery. His innovation lay in recognizing that the same engineering principles used in industrial equipment could be adapted to medical applications. The mechanical specifications of Taylor's device reveal sophisticated engineering thinking. The vibratory mechanisms could operate at frequencies ranging from 20 to 200 cycles per minute, with amplitude adjustments that allowed for customized treatment based on individual patient needs. The machine included multiple attachments designed for different therapeutic applications, demonstrating remarkable attention to functional versatility. However, the practical limitations of steam-powered medical equipment soon became apparent. The noise generated by the boiler and mechanical systems made discrete treatment impossible, while the time required to build up steam pressure meant that patients often had to wait 20 to 30 minutes before treatment could begin. The maintenance requirements were substantial, involving daily boiler cleaning, mechanical lubrication, and pressure system inspection. Dr. Mortimer Granville's development of battery-powered vibrators in the early 1880s represented a revolutionary advance in both convenience and effectiveness. Granville, who had trained in electrical engineering before studying medicine, recognized that portable electric power could solve the practical problems that limited steam-powered devices. Granville's first electric vibrator used a battery pack containing multiple galvanic cells that could provide power for several hours of continuous operation. The electrical system included voltage regulation circuits to ensure consistent motor performance, while the mechanical components were precision-engineered to minimize noise and maximize efficiency. The technical specifications of Granville's device were impressive by Victorian standards. The electric motor could operate at variable speeds up to 300 revolutions per minute, providing therapeutic frequencies that exceeded what was possible with manual treatment. The device included interchangeable attachments made from different materials, rubber, metal, and various textured surfaces, allowing physicians to customize treatment based on patient preferences and therapeutic requirements. Granville's engineering documentation, preserved in British patent archives, reveals sophisticated understanding of electrical systems and mechanical design. His vibrator incorporated several innovative features, including automatic voltage regulation, mechanical vibration dampening, and ergonomic design elements that made the device comfortable for extended use. The commercial success of Granville's invention sparked a wave of technological innovation. As other inventors sought to improve upon his basic design, the 1890 seconds saw rapid development of more powerful motors, longer-lasting batteries, and increasingly sophisticated control systems that gave operators precise command over frequency, amplitude, and duration of treatment. Hamilton Beach's 1902 patent for an electric vibrator designed specifically for home use represented another major technological breakthrough. Their device was the first to be designed from the ground up as a consumer appliance rather than medical equipment, incorporating features like attractive styling, quiet operation, and simplified controls that made it accessible to users without technical training. The Hamilton Beach vibrator featured several innovative engineering solutions. The electric motor was mounted in rubber isolators to minimize transmitted vibration and noise, while the control system used variable resistance circuits that allowed users to adjust intensity with simple dial controls. The device was designed for reliability rather than maximum performance, reflecting the company's understanding that home users needed dependable operation more than clinical precision. The manufacturing processes developed for mass-producing vibrators revealed remarkable engineering sophistication. Companies like Hamilton Beach developed specialized production techniques for winding electric motors, molding rubber components, and assembling complex electrical systems. These manufacturing innovations often found applications in other electrical appliance production, contributing to broader technological advancement. The materials science involved in vibrator production also drove innovation in unexpected directions. Manufacturers experimented with different rubber compounds to create attachments that would be both effective and durable, while electrical components required materials that could withstand repeated mechanical stress. These materials research efforts contributed to advances in electrical insulation, mechanical seals, and corrosion-resistant metals. The quality control systems developed for vibrator manufacturing were necessarily sophisticated because device failure during use could create extremely awkward situations for both physicians and patients. Companies implemented comprehensive testing protocols that evaluated electrical safety, mechanical reliability, and performance consistency. These quality standards often exceeded those used for other electrical appliances of the era. The international technology transfer that occurred as vibrator manufacturing spread globally created additional opportunities for engineering advancement. German precision manufacturing techniques combined with British electrical expertise and American mass production methods to create increasingly sophisticated devices that outperformed their predecessors in every measurable category. Dr. Wilhelm Erb's collaboration with German electrical manufacturers resulted in vibrators that incorporated the latest advances in motor design and electrical control systems. These devices featured precision speed control, automatic safety shutoffs, and mechanical systems that could operate continuously for hours without overheating or mechanical wear. The French approach to vibrator technology emphasized elegance and discretion rather than raw performance. French manufacturers developed devices with attractive styling, quiet operation, and compact designs that could be easily stored and transported. Their engineering focused on user experience rather than clinical effectiveness, reflecting different cultural attitudes toward the technology. The battery technology that powered portable vibrators also benefited from the engineering attention focused on these devices. manufacturers developed improved galvanic cells with longer operating life and more consistent voltage output, while experimenting with different chemical combinations that could provide greater power density and reliability. The emergence of alternating current electrical systems in the early 1900s created new opportunities for vibrator design. AC-powered devices could be more powerful than battery-operated units, while offering the convenience of unlimited operating time. The engineering challenges involved in creating AC vibrators included power supply design, motor control systems, and electrical safety features that would protect users from potentially dangerous household current. The sophistication of vibrator control systems evolved rapidly as manufacturers competed to offer superior user experience. Advanced devices featured multiple speed settings, reversible rotation, programmable timing functions, and even primitive feedback systems that could adjust operation based on mechanical resistance or electrical load variations. The ergonomic design of vibrator attachments reveals remarkable attention to human factors engineering. Manufacturers conducted extensive research into optimal shapes, sizes, textures, and materials that would provide maximum therapeutic effectiveness while ensuring user comfort and safety. This research often involved detailed anatomical studies that contributed to broader understanding of human physiology. The noise reduction technology developed for vibrators also found applications in other electrical appliances. The engineering techniques used to minimize operational noise included vibration isolation systems, precision motor balancing, and acoustic enclosure design that would later be applied to household appliances like vacuum cleaners and food processors. The electrical safety systems incorporated into vibrators were often more sophisticated than those found in other contemporary electrical devices. Given the intimate nature of vibrator use, manufacturers implemented multiple safety features, including ground fault protection, current-limiting circuits, and automatic shutdown systems that would prevent dangerous electrical faults. The technological legacy of Victorian vibrator development extended far beyond the devices themselves. The engineering principles, manufacturing techniques, and quality standards developed for this industry contributed to advances in electrical motors, battery technology, materials science, and precision manufacturing that would influence numerous other applications throughout the 20th century. By the 1910s, a growing number of physicians were beginning to experience what we might now recognize as professional cognitive dissonance regarding their hysteria practices. The medical establishment that had built profitable careers around therapeutic massage was starting to confront uncomfortable questions about the true nature of their treatments and the ethical implications of maintaining a collective professional fiction. Dr. Abraham Myerson, writing in his private journal in 1913, expressed concerns that would have been unthinkable a generation earlier. I find myself increasingly troubled by the disparity between the theoretical basis of hysteria treatment and the obvious nature of the therapeutic intervention. The professional literature maintains elaborate medical justifications for procedures that any honest observer would recognize as fundamentally sexual in nature. Myerson's crisis of conscience was shared by numerous colleagues who were beginning to question whether their professional integrity was compatible with continuing to provide what amounted to sexual services while maintaining the fiction of legitimate medical treatment. The emergence of psychoanalytic theory had given physicians alternative frameworks for understanding female psychology that made the hysteria delusion increasingly difficult to sustain intellectually. Dr. James Jackson Putnam, one of the first American physicians to seriously engage with Freudian concepts, wrote extensively about the ethical challenges posed by traditional hysteria treatment. In a 1914 letter to Sigmund Freud himself, Putnam confessed, "American medical practice has developed approaches to feminine psychological disturbance that, while effective in providing symptomatic relief, may not represent the most honest or scientifically sound methods of addressing underlying psychological needs." Putnam's correspondence with European colleagues reveals the extent to which American physicians were beginning to recognize that their hysteria treatments were providing sexual satisfaction rather than medical therapy. However, The professional and financial investments in the existing system made it extremely difficult for individual physicians to abandon practices that had become central to their careers and incomes. The younger generation of physicians entering practice in the 1910s brought different attitudes toward sexuality and medical ethics that challenged the established hysteria paradigm. Dr. William J. Robinson, who had studied psychology as well as medicine, wrote bluntly in 1915, "The continued pretense that mechanical stimulation of female patients constitutes legitimate medical treatment reflects poorly on our profession's commitment to scientific honesty and ethical practice." Robinson's willingness to challenge established medical authority represented a generational shift in professional attitudes. Younger physicians who had been educated in more scientifically rigorous medical schools were less willing to accept traditional practices that couldn't be justified through contemporary scientific understanding. The American Medical Association began receiving complaints from physicians who were troubled by the ethical implications of hysteria treatment. Dr. Morris Fishbein, who would later become editor of the Journal of the American Medical Association, documented several cases where physicians had requested guidance about the appropriateness of mechanical massage therapy for female patients. These professional consultations reveal the extent to which individual physicians were struggling with the moral ambiguity of their practices. Many doctors understood perfectly well what they were doing, but felt trapped by professional expectations, patient demands, and financial pressures that made it difficult to change their approach without damaging their careers. Dr. Rachel Yaros, one of the few female physicians practicing gynecology in this era, provided a unique perspective on the hysteria phenomenon. Writing in 1916, she observed, "The male medical establishment has created an elaborate system for addressing female sexual needs while maintaining the fiction that female sexuality doesn't legitimately exist. This approach serves male professional and psychological needs more effectively than it serves the actual health interests of female patients." Yaros's feminist analysis of hysteria treatment was decades ahead of her time, but it reflected growing awareness among women physicians that traditional medical approaches to female sexuality were based more on social prejudice than scientific understanding. Her critique gained additional authority because she could speak as both a medical professional and a woman who understood the patient experience from personal knowledge. The emergence of alternative medical approaches to psychological problems created additional pressure on physicians who continued traditional hysteria treatments. Talk therapy, occupational therapy, and pharmaceutical interventions offered different ways of addressing the symptoms that had traditionally been treated through mechanical massage, making it increasingly difficult to justify the older approach as medically necessary. Dr. Adolph Meyer, one of America's most prominent psychiatrists, wrote in 1917 about the need for fundamental reconsideration of medical approaches to feminine psychological disturbance that have been based more on social convenience than scientific understanding. Meyer's critique carried particular weight because of his international reputation and his role in training a new generation of mental health professionals. The First World War accelerated these professional changes by exposing American physicians to European approaches to sexuality and psychology that were far more direct and honest than traditional American medical practice. Military physicians who served overseas returned with new perspectives on psychological treatment that made traditional hysteria approaches seem antiquated and ethically questionable. Dr. Thomas Salmon, who directed psychological services for the American military during the war, wrote extensively about the need to abandon medical approaches that were based on Victorian assumptions about female psychology that have been thoroughly discredited by contemporary psychological research. His advocacy for more scientifically rigorous approaches to mental health treatment influenced a generation of returning military physicians. The economic pressures of the post-war period also contributed to changing medical attitudes toward hysteria treatment. The medical profession was becoming more competitive and specialized, with physicians increasingly focused on developing expertise in specific areas rather than maintaining general practices that included questionable specialties like hysteria treatment. Dr. Frank Billings, president of the American Medical Association in 1920, delivered a speech that many observers interpreted as a veiled critique of hysteria practice. The medical profession must maintain the highest standards of scientific rigor and ethical conduct. Treatments that cannot be justified through contemporary scientific understanding, regardless of their traditional acceptance or economic benefits, should be abandoned in favor of approaches that reflect current knowledge and professional standards. Billings never explicitly mentioned hysteria treatment, but his emphasis on scientific justification and ethical conduct was widely understood as criticism of physicians who continued to provide mechanical massage therapy while maintaining medical pretenses about its nature and purpose. The insurance industry's growing involvement in healthcare financing also created pressure for more precise medical documentation and justification of treatments. Insurance companies began requiring detailed explanations of therapeutic procedures before approving reimbursement, making it increasingly difficult for physicians to maintain vague medical language about the nature of hysteria treatment. Dr. Louis Dublin, chief statistician for Metropolitan Life Insurance Company, wrote in 1921 about the company's concerns regarding certain therapeutic procedures that appear to lack adequate scientific justification, despite their widespread acceptance within medical practice. Dublin's comments reflected growing corporate skepticism about medical treatments that couldn't be clearly explained or objectively evaluated. The emergence of medical malpractice litigation as a significant professional concern also influenced physician attitudes toward hysteria treatment. Several high-profile cases in the early 1920s involved physicians who had been accused of inappropriate conduct during therapeutic massage sessions, creating liability concerns that made many doctors reconsider their involvement in such treatments. Dr. Arthur Hertzler, writing about medical malpractice risks in 1923, advised colleagues to avoid therapeutic procedures that might be subject to misinterpretation or that require intimate physical contact without clear medical justification. His warning reflected growing awareness that hysteria treatment could expose physicians to professional and legal vulnerabilities that outweighed any potential benefits. The development of formal medical ethics codes also created new standards for evaluating the appropriateness of traditional practices. The American Medical Association's evolving ethical guidelines emphasized the importance of informed consent, scientific justification, and professional boundaries that were difficult to reconcile with traditional hysteria treatment approaches. Dr. Chauncey Leake, who played a leading role in developing medical ethics education, wrote in 1924, "Professional ethics require that physicians honestly acknowledge the true nature of their therapeutic interventions and ensure that patients understand what they are receiving and why. Medical treatments that require maintaining fiction about their essential character are incompatible with ethical medical practice." The generational transition within the medical profession accelerated the abandonment of hysteria treatment as older physicians retired and were replaced by younger practitioners who had been trained in more scientifically rigorous medical schools. The new generation of physicians was less willing to accept traditional practices that couldn't be justified through contemporary scientific understanding. By 1925, the combination of scientific skepticism, ethical concerns, legal liability issues, and generational change had created a professional environment where hysteria treatment was becoming increasingly difficult to justify or maintain. The medical establishment was finally ready to abandon the elaborate fiction that had sustained this practice for over half a century, though. The transition would require careful management to preserve professional credibility and avoid acknowledging the full extent of what had actually been occurring. While Victorian society was maintaining its elaborate pretense about medical massage and therapeutic devices, a profound social revolution was quietly transforming women's lives, relationships, and expectations in ways that nobody could discuss openly, but everyone could observe indirectly. The vibrator phenomenon had accidentally created the first generation of sexually autonomous women in Western history, and the ripple effects were transforming society from the inside out. The demographic evidence for this transformation is subtle but unmistakable when examined carefully. Marriage patterns among middle-class women began changing significantly in the 1890s, with women increasingly likely to delay marriage, be more selective about potential husbands, and negotiate for better terms within marriage. Census data shows that the average age of first marriage for educated women increased by nearly 2 years between 1890 and 1910, while divorce rates climbed steadily throughout the same period. What the statistics don't reveal, but contemporary observers noted, was that women were becoming far more assertive about their personal needs and expectations within intimate relationships. Dr. Clelia Duell-Mosher's interviews with married women revealed that those who had access to medical treatments were significantly more likely to communicate directly with their husbands about sexual matters, express dissatisfaction with inadequate intimate relationships, and take active steps to improve their marital situations. Mrs. Frances Willard, the prominent temperance leader, wrote in her private diary about the mysterious transformation she observed among women of her acquaintance. There seems to be a new confidence and self-possession among the ladies of my circle that I find both admirable and somewhat puzzling. They appear to have discovered something about themselves that gives them strength to demand more from life than previous generations would have considered appropriate. What Willard was observing, though she couldn't name it directly, was the emergence of women who understood their own sexual capacity and were beginning to insist that their relationships acknowledge and satisfy those needs. This represented a fundamental challenge to Victorian assumptions about feminine nature and domestic harmony. The economic implications of this sexual awakening were equally significant. Women who had experienced sexual autonomy through vibrator use were more likely to seek economic independence as well. They were more likely to work outside the home, start their own businesses, pursue higher education, and make financial decisions independently of male authority. The correlation between sexual autonomy and economic autonomy wasn't coincidental. Both represented assertions of personal agency that Victorian society had traditionally denied to women. Dr. Catherine Bement Davis's research revealed fascinating patterns of behavior among college-educated women who had access to therapeutic massage treatments. These women were more likely to delay marriage in favor of pursuing careers, more likely to remain single by choice rather than settling for unsatisfactory relationships, and more likely to negotiate prenuptial agreements that preserve their economic independence, even within marriage. The impact on family dynamics was equally profound, though rarely discussed openly. Mothers who had never experienced sexual satisfaction found themselves trying to relate to daughters who took it for granted. The generational divide created tensions that surfaced in debates about appropriate feminine behavior, educational opportunities, and social expectations. Mrs. Elizabeth Cady Stanton, writing to her daughter Harriet in 1895, expressed confusion about the changing attitudes she observed. The young women of today seemed to possess a self-assurance and sense of personal entitlement that was unknown in my generation. While I admire their confidence, I sometimes wonder if they fully understand the social forces they are challenging through their independence. Stanton was documenting the emergence of what we might now recognize as sexually liberated women, though she lacked the conceptual framework to understand what she was observing. Her daughter's generation had grown up with access to reliable sexual satisfaction through medical treatment, which had taught them that their needs and desires were legitimate and deserved acknowledgement. The religious implications of this transformation created additional social tensions. Victorian Christianity had been built on assumptions about feminine purity and self-sacrifice that were increasingly incompatible with the behavior of women who understood their own sexual capacity. Church leaders found themselves struggling to address changing attitudes toward marriage, sexuality, and women's roles without acknowledging the underlying causes of those changes. Reverend Washington Gladden, one of the era's most prominent Protestant ministers, wrote in 1902 about the challenges posed by changing feminine attitudes toward domestic responsibility and marital duty. He noted that younger women seemed less willing to accept traditional teachings about self-denial and submission, though. He attributed this to modern influences, rather than recognizing the role of sexual awakening in fostering greater personal autonomy. The educational establishment also confronted the implications of changing feminine expectations. Women's colleges reported that their graduates were increasingly likely to pursue careers rather than immediate marriage, more likely to demand equal treatment in professional settings, and more likely to challenge traditional assumptions about feminine capabilities and limitations. Dr. M. Carey Thomas, president of Bryn Mawr College, wrote in 1905 about the remarkable transformation in feminine self-concept that she observed among her students. The young women of today possess a confidence in their own capabilities and a determination to achieve their personal goals that would have been considered unseemly in previous generations. They seem to have discovered inner resources that give them strength to challenge social expectations and pursue their individual ambitions. Thomas was describing women whose sexual autonomy had fostered broader forms of personal empowerment, though she couldn't acknowledge the connection directly. The students she observed had grown up in an era when female sexual satisfaction was increasingly available through medical treatment, which had taught them that their needs mattered and deserved attention. The impact on male-female relationships extended far beyond marriage to influence social interactions, professional relationships, and political movements. Men found themselves dealing with women who were more confident, more demanding, and less willing to accept traditional power arrangements. The result was a gradual but fundamental shift in gender dynamics that would eventually transform American society. Dr. G. Stanley Hall, the prominent psychologist, wrote extensively about what he perceived as increasing masculine qualities among contemporary women. He noted that younger women were more likely to express opinions forcefully, pursue competitive activities, and assert themselves in mixed-gender social situations. Hall interpreted these changes as evidence of concerning social trends, but he was actually documenting the emergence of sexually confident women who no longer felt compelled to maintain facades of helpless femininity. The political implications of this transformation became apparent in the increasing militancy of the women's suffrage movement. Women who had discovered their own power through sexual autonomy were naturally more willing to demand political power as well. The correlation between access to vibrator technology and support for women's rights wasn't coincidental. Both represented aspects of the same fundamental assertion of feminine agency. Mrs. Carrie Chapman Catt, president of the National American Women's Suffrage Association, noted in her correspondence that the most effective suffrage activists were often women who possessed what she called an unusual degree of personal confidence and self-possession. These women were more willing to challenge male authority, more comfortable with public speaking, and more persistent in pursuing their political goals. The international dimension of this social transformation became apparent as vibrator technology spread to other countries, and similar changes in feminine behavior emerged globally. British suffragettes, European feminists, and women's rights activists throughout the Western world began exhibiting similar patterns of increased assertiveness and political activism. The labor movement also benefited from the growing confidence of sexually autonomous women. Female workers became more willing to organize unions, demand better working conditions, and challenge discriminatory employment practices. The correlation between access to sexual satisfaction and willingness to assert economic rights reflected the broader relationship between personal autonomy and political empowerment. The consumer culture that was emerging in the early 20th century was profoundly influenced by the changing expectations of women who had discovered their own needs and desires. Advertisers began targeting female consumers more directly. Manufacturers developed products specifically designed to appeal to women, as preferences and retail establishments adapted their approaches to serve increasingly sophisticated female customers. The cultural productions of this era, literature, theater, fashion, and popular entertainment, began reflecting the changing realities of feminine experience, though always in carefully coded language that maintained social respectability. The new woman who appeared in novels and magazine stories was often a thinly veiled representation of the sexually autonomous woman who had emerged from the vibrator revolution. By 1910, the social transformation was becoming impossible to ignore, even though its underlying causes remained unacknowledged. American society was dealing with a generation of women who possessed fundamentally different expectations about their relationships, their opportunities, and their rights compared to their mothers and grandmothers. The vibrator had accidentally created the psychological and social foundations for the feminist movements that would reshape the 20th century. The revolution that nobody could acknowledge was reshaping society more profoundly than most political or economic changes, creating new possibilities for human relationships and individual fulfillment that would eventually transform not just women's lives, but the entire structure of American social organization.